Welcome to this educational presentation entitled Sports Concussion, One Family's Diagnostic Journey. In this film, we'll follow the 6-year medical journey of one family whose son received a sports concussion, his diagnostic course, and long journey toward healing. The family shared his medical records and his story in hopes of helping others. Our purpose is not to prove errors of diagnosis after the fact or assign blame to any practitioners. We weren't there and can't know for sure. We aim to identify common pitfalls that can steer diagnosis off course so that others may avoid those pitfalls. And we will also present what has changed in recent years in our understanding of head injury. We'll be presenting the case of Charles, age 16 at the time of his injury. 6 years later, we asked several physician specialists who were not involved in Charles' care to make general comments, not specific to his case. Our purpose is to assist practicing physicians to identify what can be done now to improve recognition of concussion injury, prevent further harm, and promote maximum recovery. We'll begin with a chronology. Charles was 16 in September of 2009. He was close with his 3 younger siblings. He had many friends and he was doing well in school. He'd just gotten his driver's license and had driven himself to play in a school soccer game. A few minutes into the game, he received an impact from behind. He fell and hit the back of his head. Neither his coach nor his parents in the bleachers saw him fall. He got up, shook it off, and played out the entire 60-minute game. Afterward, he told his mother his head hurt from a fall. He was feeling dizzy and wobbly. He asked if he could leave his car at school and ride home in the family car.
When we got home, Charles was complaining of a headache, and so I told him to take a couple Motrin and go lay down in a dark room, and if he wasn't feeling better, an hour or so to come get me.
When he came down to talk to my wife, Michelle, about his headache not going away and his dizziness, and we looked at his pupils, we saw that it weren't dilating, and we both kind of decided that he should go to the emergency room.
The emergency physician noted the head injury and Charles' report of clear fluid coming from his nose at the time of the fall, and subsequent dizziness, nausea, visual disturbances, and persistent headache. In the emergency department, Charles had a CT scan of the head, which was reported as negative. He received medications for nausea and headache. He was diagnosed with closed head injury and concussion. This ED visit was on a Friday night in September. His parents recalled being instructed by the physician to keep him quiet over the weekend, and that if he was feeling better, he could return to school and sports activities on Monday. The written discharge instructions said he should follow up with his PCP and could return to playing sports the next day. Charles returned to school on Monday, but didn't drive his car or attend PE class right away. But 2 weeks after the injury, he had returned to full activities, including PE and soccer practice, which included header drills.
That means that you hit the ball with your head to the partner hits it back, and you just keep going until they blow the whistle. And it's usually about 5 minutes of going back and forth, hitting the ball with your head.
At about the same time he returned to soccer practice, Charles developed cold or flu symptoms, headaches, and profound exhaustion. He went to bed and stayed there. His parents assumed he had recovered from the head injury and did not connect his symptoms with it. When Charles did not get better, they took him to see his family doctor, who was unaware of the head injury. She noted cough, sore throat, and nasal congestion, weight loss, and the fact that Charles was unable to attend school. She diagnosed a viral illness, prescribed azithromycin, albuterol inhaler, rest, and fluids. After a few more days, Charles still did not improve. He went back to the PCP and was tested for mono. The PCP also ordered chest x-rays and a CBC. Everything was negative. According to his parents, Charles was sleeping up to 20 hours per day at this time. After another 2 weeks, Charles was still home from school and still spending most of his time in bed. The PCP suspected Epstein-Barr, CMV, or some other infection. She referred Charles to an infectious disease specialist who performed blood tests, but the tests were all negative. 8 weeks after the head injury, the PCP learned about the head injury for the first time from the mother. She then ordered an MRI of the brain, but the MRI was negative. Charles was noted to be sleeping about 16 hours a day at this time. By 11 weeks after the injury, Charles had missed most of the fall semester at school. His PCP noted he was depressed and sick, had a headache, and slept most of the day. She diagnosed him with depression and prescribed an antidepressant, Midrin for headache, and physical therapy. At the end of January, 4 months post-injury, Charles returned to school for the new semester and even tried to play rugby. He found it difficult to concentrate and couldn't take his science and math courses. He took only English and 2 other academic classes.
He'd come home and he'd sleep. From the time he got home like around 2:30, and we'd eat like around 6:30, 7-ish. And he would get up at that point, eat dinner, do his homework, and go back to bed until he was ready for school in the morning.
In February, 4.5 months post-injury, the PCP noted his continued sleeping disturbance and persistent headaches since the injury in September. She advised no sports till the headaches resolved and also advised better sleep hygiene. Since Charles did not want to go to physical therapy, the PCP suggested he might want to try acupuncture. After 3 sessions of acupuncture, Charles said he thought it helped his headache. Charles began to slowly improve throughout the spring semester, and the family was hopeful this was the end of it. However, this was not to be. At the end of May, he and his parents and 3 younger siblings took a cross-country flight to attend a family wedding. His symptoms came back. He was nauseated and vomited. His sleep problems returned as bad as ever, and he spent much of the trip in bed. Upon his return home, the PCP noted increased depression, anxiety, and social withdrawal. She increased Charles's antidepressant medications and ordered a consultation with a psychologist. Charles went to see the psychologist. Upon examining him, the psychologist noted depression and wide mood swings. He made a number of changes to the antidepressant regimen over many weeks. He ordered a neurotransmitter test, a hormone test, and recommended a consultation to a neurologist and a naturopath. It was now 10 months post-injury. In July, there was a second family wedding across country. Charles asked not to go, begged not to go, but his parents were afraid to leave him home alone, so the whole family boarded another flight. This time, his symptoms returned harder and faster.
The whole flight, his head was killing him. He started complaining right away that he was having these huge headaches. When we got to the town we were going to, he immediately was like isolating himself, going to the room, but also he ended up having these jitters. He was shaking. Like his legs couldn't stop shaking, his hands couldn't stop shaking.
In addition to the tremors and severe headaches, Charles was also experiencing sound and light sensitivity.
We actually entertained thoughts of just driving him back to where we lived, across country. Again, we talked to some doctors. Should we do this? Is the flight going to be an issue? But they kept telling us no, it shouldn't be. You can fly him back. So we did. When we got back to our hometown, it was Charles took a really steep downturn at that point.
Upon his return home, Charles was worse than ever before. He had extremely slow mental processing and difficulty focusing. He went into social withdrawal. He retreated to his bedroom, locked the door, and turned out the lights. He didn't make eye contact and only engaged with his family or doctors when necessary. He begged to be left alone.
Then he started saying he didn't want his friends over. And he would look at me and he'd say, just as serious as could be, with like these pleading eyes, don't let my friends come over, don't want them to see me like this.
11 months post-head injury, Charles was referred to a neurologist. The neurologist ordered numerous blood tests which turned out normal, except for a low vitamin D. Charles underwent a waking and sleeping EEG. Physical therapy was consulted for the headaches. Lamotrigine was started in addition to the antidepressant. The parents asked the neurologist if the head injury could be causing these symptoms. The neurologist told the father that only a few of his symptoms were related to the head injury, possibly the headaches from flying, but concussion was not the major factor. At this point, Charles was voicing paranoid thoughts and sometimes hearing voices. Schizophrenia was discussed as the possible cause. A nutritionist was consulted who ordered allergy testing and diagnosed a gluten allergy. A homeopath was consulted. The homeopath diagnosed pseudo-Parkinson's symptoms and ordered food supplements, vitamins, craniosacral treatments, and a rotation diet. Meanwhile, his father reported that Charles had gotten much worse. He looked scared, and he told his father he felt people were watching him. He complained of seeing security cameras everywhere, in buildings and on the street. Once he became agitated when he and his family were eating in a restaurant because of cameras and because he saw a policeman enter the restaurant wearing a holstered gun. There was another instance at a family dinner.
Michelle was like making some bread, buttering some bread, and he was over there getting his dinner, and she's like pointing the butter knife at him, so you want me to butter your bread? And he just got this looking like she was going to kill him. He just got that really scared look, and she wasn't understanding what she was saying. He just looked like he started backing up. And I almost had to sit there and slowly explain to him, I had to put the knife away. Do you want butter on your bread for him to really comprehend it? So those are the kind of incidents that I think, made doctors wonder what else was going on here, because it just seemed like this total degradation of his, senses at that point.
Charles told his mother that she focused too much on his head injury and asked her not to keep bringing it up at doctor's visits. He voiced great fear at what was happening to him. Charles did not return to school for his senior year.
I think in his mind, he thought that something was going on, that he was going crazy, having some psychological problems.
I wasn't even thinking about school at that point. We were just thinking about his general health and trying to get him safe.
A full year after the injury, Charles saw a psychiatrist for the first time. The psychiatrist noted a history of brain trauma and diagnosed major depressive disorder. The psychiatrist referred him to an endocrinologist and a neuropsychologist. Over the better part of that year, Charles underwent countless tests, medication changes, and consultations with providers in numerous specialties. He and his parents virtually lived in doctors' offices. The doctor's visits were a stress and strain on the whole family and on Charles in particular.
That was probably the scariest point, because he really wasn't able to communicate as well as he normally could, and so you didn't know what was 100% going on with him. Like, what kind of noises was he hearing? Was he really hearing voices or not? And I think every night we went to bed worried that is he going to kill himself? Is that something going on? Is that really going through his head? He's afraid to share it with us. I think for months, probably almost a year, we were just worried about that.
2.5 years post-injury, he and his family moved out of state, established care with other physicians, and Charles embarked upon 40 hyperbaric treatments. At 3 full years after the original head injury, a neuropsychologist wrote that the head injury was at the root of Charles' problems, exacerbated by a premature return to activities. His severe head injury symptoms led to a state of major depression. The number and doses of his psychotropic medications were gradually reduced.
He was on very high doses of all this stuff. He was a lot of time they would keep give him higher and higher doses, and they say, oh, this is going to really have an effect, and it would come back and there's no effect. And it's like they got to recognize that, well, this medicine's not helping at this point. Then the problem was we weren't sure whether it was just more damage from the head injury or just not dealing with it right, or was it because he was on these medicines combined with the head injury having side effects. But when we started pulling him off the medicines and doing some other treatments, he started getting a lot better. And again, I think it was mainly due to the treatments, and I think the medicine may have some minor side effects, but you never know at that point. You wonder.
Over the 3rd, 4th, and 5th years post-injury, Charles gradually improved on a curve that accelerated in the 4th year and really took off in the 5th. We may never know if this improvement was due to the passage of time, the hyperbarics, lifting the fog of psychotropics, or the brain growth and development typical of late adolescence, or all of the above. In 2014, 5 years post-injury, he resumed driving a car and passed his GED test. In 2015, at 22 years of age, despite persistent sleep problems and unwanted weight gain due to the antidepressants, he's finally returned to a mostly normal state. He attends a junior college, gets A's in his math courses, tells jokes, surfs the internet, plays basketball, and socializes with old friends. He doesn't remember much about his lowest period post-injury. He agreed to his records being shared and his family being interviewed for this film in the hopes it would help other people with head injury. Since 2009, concussion has increasingly been in the public eye due to the professional football players' claims against the NFL and soldiers' brain injuries from explosives. In 2013, the Institute of Medicine's expert panel reported that little is known about how to prevent, diagnose, or manage concussive head injury. And yet, every day physicians are charged with doing so. Charles's story appears on the surface to be the story of mistaking a head injury for depression, involving many practitioners in many specialties over a long period of time. But it wasn't quite that simple. There were many confounding factors, diagnostic pitfalls, and a lot has been learned about head injury in the meantime. So let's take these factors apart one by one. We talked with Dr. Aaron Carlin, a physical medicine doctor and head injury expert. We asked him to explain first, what is concussion and what is known about it today?
We've learned a lot about concussions in the past 10 or 15 years so that we treat them very differently than when I was a child. It's a type of traumatic brain injury, so a brain injury induced from a trauma, either a direct hit to the head or a hit to the body, and then that force can be transmitted through the neck to the brain, injuring the brain. We've learned that you don't have to be knocked out to have a concussion. Less than 20% of concussions are associated with loss of consciousness. So that old adage is a misnomer at this point. The analogy that I use frequently about what a concussion is an old-time telephone switchboard operator. That individual who's got to put in the different pegs to connect to different phone calls. And the idea is that someone came to that person's telephone switchboard with a baseball bat and hit it, and a bunch of pegs get knocked out. And however long it takes that telephone switchboard operator to put all those pegs back in, put them in the right holes, and to have them stay is how long it takes for that brain to heal. So you can imagine then that no two concussions are going to be alike. It depends on what pegs get knocked out, how many pegs get knocked out, and how quickly that individual's operator is functioning to put those pegs back in the first place. So those pegs then correspond to the different signs and symptoms that we see with concussions, and they generally come in about 4 groups. First are physical signs and symptoms: headaches, nausea, vomiting, lightheadedness, dizziness, light hurting your eyes, sound hurting your head, vision changes, neck pain, balance problems, ringing in the ears, things like that. The next group that I tend to look at are cognitive changes: trouble with memory, trouble with math, trouble with word finding, slowed reaction time, slowed processing speed, difficulty maintaining focus, attention, concentration, feeling mentally foggy or slow. Next group of changes is going to be sleep disruption. Your brain's in charge of when you're awake and when you're asleep. So these can be individuals who are normally good sleepers all of a sudden having trouble falling asleep, or falling asleep fine but waking up multiple times through the night, or the exact opposite. Tired all the time, excessively fatigued, taking daytime naps, sleeping 12, 14, 16 hours a day. And the last group that we tend to look at are emotional changes, because your brain's in charge of your emotions as well. So these are kids or adults that are normally pretty even keel, and all of a sudden happy, sad, angry, glad, crying for no reason, excessively irritable, short fuse, snapping at people that they normally wouldn't, or the exact opposite, flat, withdrawn, robotic. So those are the signs and symptoms that we're looking for with a concussion. They can be seen immediately after a hit to the head or the body, or they can come on 24, 48, sometimes even a couple more days after the fact.
For Charles, the CT of his head in the ER and later the MRI were both negative. Should that have been reassuring?
CAT scans are used frequently in the emergency room in evaluation of individuals with closed head injuries, which I would say is unfortunate. The analogy that I use, if you remember, about the concussion is the old-time telephone switchboard operator and someone coming by and hitting that switchboard and the pegs being knocked out. Well, a CAT scan or an MRI basically just takes a picture of that switchboard. So if you took a picture of that switchboard before and after it got hit, the switchboard would look identical. You wouldn't see any changes to that switchboard whatsoever. The important thing with a concussion is that a concussion is a functional disturbance to the brain. It's not actually an injury to the brain parenchyma or the brain tissue itself. That can happen with certain types of cerebral contusions or other bleeds that you might see on the brain, and in that case, CAT scan and MRI can be very helpful, but that is certainly less than 1% of the time. The unfortunate piece is that a number of these individuals that come through the emergency rooms and get CAT scans are being irradiated. And that's a good amount of radiation from the CAT scan.
It seems the disruption of those neural connections is essentially invisible with our current imaging technology. So if CT is not appropriate for sports concussion, when is it appropriate?
So in general, we reserve the use of imaging in individuals who are involved in high speed or high velocity motor vehicle collisions, things that we're going to be concerned about, a skull fracture or potentially an intracranial bleed, but more for skull fracture, or in individuals who are having persisting symptoms. Those generally in my practice that are having symptoms beyond 6 weeks or longer. One of the other potential problems with using a CAT scan that I've seen, unfortunately, is that with a normal CAT scan, which again has very limited value when it comes to concussions, practitioners, physicians, but even coaches and parents will hear that, oh, the CAT scan was normal, oh, my child must not have had a concussion, and can get sent back prematurely, even though they're still having continued symptoms.
What about the clear fluid coming from Charles's nose immediately after the injury? Was it cerebrospinal fluid? If so, wouldn't that signify a structural injury that should have been picked up on imaging? We asked emergency medicine physician Keith Van Meter about the significance of fluid from the nose in head injury.
When a patient has fluid coming from the nose, it's called rhinorrhea, or from the ears after a head injury, it is particularly important for the suspicion of a basal skull fracture to be suspected. And a basal skull fracture occurs when there's a tremendous amount of focused energy put into the brain case, the bones or the covering of the brain, the skull. And if that has occurred, then the brain, which sits on bony territory at its base that is got sharp edges, is padded, yes, with cerebrospinal fluid, which encases the entire brain. The brain is impacted and can have coup or counter-coup energy transmission, or even worse, rotational energy transmission into it to disrupt those axons that we talked about for the diffuse axonal injuries, or the injuries that can't often be seen on CT. The CT is reasonably good at seeing bony injury structure, but not much help in a rhinorrhea after brain injury, because often it's very hard with a CT to see a basal skull fracture. It's more often not seen than seen. And then also because the CT misses the subtle injury. And so the CSF, or the cerebrospinal fluid coming from the nose, like a runny nose, is really a signpost to the potential of tremendous energy abruptly transmitted rotationally or linearly into the brain, and concussion.
So it is entirely possible for there to be a basal skull fracture and it not show up on CT. If Charles had such a fracture, it might possibly explain the fluid from the nose. But that's a mystery that cannot be solved at this point. We'll have to be satisfied with learning that it is possible for a basal fracture to not show up on imaging. Concussion is diagnosed primarily by history and examination. There is a history of an impact, an observation for the 4 types of symptoms that a patient may develop post-injury: physical, emotional, cognitive, and sleep disturbances. And we also learned that the negative CT is a diagnostic pitfall in sports concussion. It contributes to an assumption that the injury must not be very significant, and it may lull provider and patient into thinking it's okay to resume normal activities before it is okay. We now know there can be widespread disruption of those neural connections. This disruption will not show up on imaging, and it may not be wise to perform a CT for sports injuries in the first place. Parents may demand a CT scan for their child with a head injury. They may demand the child be admitted to the hospital for observation. They may expect to see some treatment ordered. This can be another pitfall. Doctors are trained to order treatments, and parents expect their child to receive treatment. What happens when there is none in the conventional sense?
There is a phrase that is alien to emergency medicine, and that's tincture of time. And it is a therapeutic modality because the body definitely wants to, in wounding, like a concussion is a form of wounding, come back to equilibrium, to an uninjured state as best it can, or to come back to a state where even if the repair has in itself been a bit injurious because of the inflammatory states that occur during repair, that new pathways are retrained and that the body can recover. And it takes time for all of that to happen. So time lets a wound unfold to its advantage to reinstate the patient with repair. If you need sleep, as sleep is so healing, there's some very intriguing sleep theories as to why every mammal and even reptile needs sleep. It is extremely regenerative.
We know that it's not just about physical rest anymore, not just no running, jumping, lifting weights, playing sports, because one of the things that your brain does that your ankle or your hamstring doesn't do is that it thinks. So things like TV, computer, video games, texting, telephone, homework, movies, music, iPod, iPhone, iPad, I this, I that, all that kind of stuff is like flexing your brain muscle. And you wouldn't run on a bum hamstring or a bum ankle. So we want to limit those kinds of activities that are flexing that brain muscle or stressful to the brain from a cognitive standpoint. And there's no definite general rule of thumb, but what I oftentimes use in my practice is 30 minutes on, 30 minutes off while that individual is still symptomatic from their concussion. And that's not a hard and fast rule. If you watch television for 35 minutes, your head's not going to explode or anything like that. But the idea is to keep it to a minimum, at least in the early acute phases while we're having that brain heal.
Ordering rest in this busy day and age runs into a lot of barriers. Doctors are pressured to release workers to return to work. Students are expected to be in school unless they have a sick note. Athletes are supposed to tough it out and show up for practice. We're conditioned to think we should be operating at full speed unless we are actively under medical treatment. Generous rest and sleep and time to recover from an injury that no one can see, that just goes against the grain. We don't know what Charles's symptoms were in the first 2 weeks post-injury, but they weren't enough to attract serious attention in a busy family of 6, and there was no medical checkpoint before he returned to normal activities. Things have changed since then. Since 2009, most of the states have put protective legislation in place for student athletes with a head injury to promote that rest and healing. Dr. Carlin helped write his state law.
Here in Louisiana, we were the first state in the Deep South to have a law on the books regarding youth concussion, and the 25th in the United States. And the 3 basic tenets to it, first of all, was any child who's had a concussion should be removed from the game or practice and is not allowed to return back to that game or practice. The second piece of it is a very important piece in that child then suspected of a concussion needs to then be evaluated by a physician or appropriate health care provider, and that's spelled out in the legislation, that in order to be cleared to come back to play. And generally, the accepted way to do so is in a graduated return to play fashion. The final piece is an educational piece. And this is important in that it requires all coaches, whether they're employed or volunteer coaches, and those individuals involved with even administration of those athletic leagues to undergo education on concussion each year annually, either online or through a actual curriculum through their league. And the last piece is that every parent needs to sign a form, an informational form on head injury and concussion, stating that they're aware of the program that's in place and has some information about concussion signs and symptoms for them to be aware of.
So the state laws now require that a head-injured player shall be evaluated by a physician or other provider to be cleared, and then will return to play in a graduated or gradual fashion. In Charles's case, the coach didn't see him fall, so the protocol would not have been activated even if the law had been in place. Charles just kept playing.
A lot of athletes won't tell their coaches, won't tell their teammates that they are having those symptoms for a number of reasons. One, They're just simply not aware of it. Also, another reason why a lot of these individuals, especially the student athletes, will hold in that information is they just want to play. They're told to play through pain. It's okay in some instances to play through an ankle sprain or a contusion on the arm, but a concussion should never be anything that somebody plays through. It's better to, the adage is it's better to miss one game than an entire season.
From what we can tell, and remember this was 2009, it was pretty much left up to Charles to say when he felt ready to return to activities. He did not see another physician before returning to sports, so we have no medical record, no physical examination, and the family doesn't have much recall about his condition in the 2 weeks after his injury. So how would one know when to clear an individual for regular activities?
So there are 4 criteria that people need to meet that we generally accept and utilize in the clinic setting that they would need to meet in order to be started back on a graduated return to play, return to work, or return to school schedule. First and foremost, we'd like them to be 100% back to their pre-injury, pre-concussion baseline in terms of any kind of concussion-related symptoms that they may have been complaining of after their head injury. Next, we like to see a completely normal neurologic examination in the office. We also incorporate vestibular or balance testing, which we'd like to see at a norm as well. And then finally, we will utilize neurocognitive testing, either paper and pen or computerized neurocognitive testing to look at that individual. And we'd like to see them either back to a pre-injury baseline, if we have that for comparison, or at least within age-adjusted norms. After that, you begin that graduated return to play. Going back to school and doing light aerobic conditioning for 30 minutes a day is the first step. Next step after that is full aerobic conditioning, doing some non-contact position drills, throwing, catching, shooting hoops, kicking a soccer ball, hitting a tennis ball, things like that. That can be done at home or that can be done under the guidance of an athletic trainer or your coach at practice. The next step after that is doing a full non-contact practice and then including some resistance strength training activities. We hold off on strength training until a little bit later, not because we're trying to get them back into shape, but actually that's harder on your brain. When you tend to do push-ups or bench press or things like that, you do something called Valsalva, or you bear down. That increases the pressure inside your head, putting more load on the brain and potentially setting off symptoms that you were having before. Each one of these steps that I've alluded to increasingly puts more strain or load on the brain, so we're essentially kicking the tires of that brain a little bit harder each time to see if any symptoms come back. If you complete that step without any return of symptoms, then you go on to the final step, which would be a full contact or collision practice, doing controlled hitting drills, for example, in football, or headers with soccer. After you finish that, then you're cleared to return to gameplay without restrictions. Anytime during that return to play protocol that you have any return of symptoms, the individual is to rest until they're symptom-free for a predetermined period of time that's individualized to that individual's concussion history, and then resumes back at the last step in which they tolerated.
Dr. Carlin warns the danger of an individual returning to regular activities before the original injury is healed is that the individual is at greater risk of a new injury, which he says takes less of an impact to do, and the symptoms tend to be more severe and longer lasting.
The problem there is that it takes longer then for that brain to finish its complete healing. Most folks are better from concussions back out on the field, 80 to 85% by 3-4 weeks. Those that aren't, though, are in what's called post-concussion syndrome territory. And for every week and for every month that you continue to have symptoms beyond that period of time, it can become harder and harder for that operator to put those pegs back into the switchboard that I alluded to.
The patient from having one concussion event almost invariably has diffuse axonal disruption and inflammatory events that have occurred in the brain. And if they have not settled down over a healing period, and often now it's felt to be about 10 days, but sometimes it can be much longer on the severity of the injury. If they go back and re-injure on top of an injury, it would be much like having a venous insufficiency ulcer on your leg that's just about healed with thin skin, and hitting it again, and it surely will reoccur much faster than on intact skin on the same extremity. Well, the brain is wounded, actually. It's just a different type of wound, but it is wounded, and if it's reintroduced to impact injury again on the order of a concussion, it stands just much like a standard wound to be worse for its non-structural integrity that goes into the injury in the first place by the first injury.
So a new head injury or insult takes less impact to do more harm and more long-lasting harm. When Charles returned to soccer practice after 2 weeks, he came down with fatigue and flu-like symptoms and took to his bed. When he didn't get better, his parents took him to his PCP. They thought the head injury was behind him, so they didn't mention the head injury. But with 6 years worth of hindsight, it looks like he had incurred a new head injury or insult when he returned to soccer practice. After a few weeks in bed, the PCP diagnosed Charles with depression and began treating him with antidepressant medication. Was this a mistaken diagnosis, or was Charles both head injured and depressed? We asked Elmore Rigamer, a child and adolescent psychiatrist, to comment on the relationship between head injury and depression.
Depression and the symptoms of concussions overlap. Many of them are the same. It's difficult to disentangle them because they both have multiple etiologies. But I would say, especially in young people, that depression is one of the symptoms that you see in a recovering child or adolescent who has had a concussion. Indeed, in some studies, about 60% of children and adolescents who have had a brain injury have depression as part of the recovery. It's common. So this population is especially vulnerable to head injury, but also the differential diagnosis is not as neat or as clear as it would be in someone older, an adult, because so many psychological dynamics are going on as part of normal child and adolescent development.
It's clear Charles had a lot to be depressed about, but no one was able to explain to him that his steep decline in functioning was precipitated by the head injury. About 6 months after starting antidepressant medication, Charles came to believe he was losing his mind, and he told his mother to quit bringing up to the doctors that he had a head injury. Would it have helped if the doctors and parents had been all on the same page at an earlier point and told him that his symptoms, including the depression, were all related to the head injury?
One really important thing in the beginning, after the event takes place, is to sit down with the patient, parent and child, and explain what you're going to go through as a result of this concussion. And depression may be a part of it. So you lay out all the symptoms at the same time that you are explaining the diagnosis by laying out the symptoms. You are talking about recovery, and you're predicting what you will feel in recovery. And I think that will go a long way toward the patient, child or college student, managing the depression if he knows, I'm feeling like this because I have this concussion.
Another mystery is whether the antidepressant medications and psychotropic medications might have been hurting more than they were helping, especially as the doses escalated. Or was it necessary and appropriate to double down on them as Charles' symptoms became worse?
In considering whether to prescribe psychoactive medications in a person who has had a traumatic brain injury, there are a lot of factors that one should take into account. First of all, has the individual had a previous history of a mood disorder or any kind of psychiatric problem? And also, is there a family history of a mood disorder? With most of these, we're talking about depression. So is there an individual or personal history of a mood disorder? Secondly, what does the patient think about his feelings or her feelings? What do they understand about this depression? Have they had appropriate education about the syndrome? And do they understand that depression is to be expected as part of the recovery from this injury? Because I believe that in itself, that type of anticipatory guidance can be very helpful. If I were prescribing an antidepressant, a selective serotonin reuptake inhibitor, I would choose one with a short life rather than a longer life. I would go slow and go low in administering the medication. I'd start at a low dose and proceed up quite slowly, gradually. These medications come with some side effects, which are oftentimes not pleasant and the side effects are a reason why people quit the medication prematurely. Again, everything that I'm doing, I would want to explain to the patient, adolescent, adult, even child, what I'm doing, why I'm doing it, what they think about it. And that helps, I think, strengthen the therapeutic alliance and guarantees a better chance at compliance.
Another mystery is the air travel. Charles' symptoms got worse when he made his first cross-country flight. He went back to his previous low point. Upon taking the second trip, he actually got worse than he had ever been.
The plane flight is a period of non-movement, of subtle off-gassing, and of low oxygen inadvertently. And not in everyone, but in some brain-injured patients, it actually is enough of a stress to put them into demonstrable symptomatology of some kind. If it isn't looked for, it'll never be seen.
In addition to emergency medicine in the conventional setting, Dr. Van Meter is a longtime expert in treating deep-sea divers with the bends, a different type of brain injury. He compares the two.
And I'll tell you, it is exactly like, again, going back to diving medicine, which went through this whole stage that concussion is going through now, many years ago, where when we didn't look for anything, the divers were returned to diving rather quickly right after injury, central nervous system injury. And now there's 9-month wait periods before a commercial diver can go back in. The industry had to get behind it, which they have very responsibly, and the government had to the U.S. Navy had to get behind it, which they have very responsibly. And it looks like the CDC and the physician community is responsibly getting behind concussions. Just think of it, if we were to go to the slopes of Pikes Peak in 5 minutes, we'd be a little breathless. Even if we were conditioned, even if we were an athlete, we'd be a little breathless. We'd be breathless because we would be breathing about 17% equivalency of oxygen, not 21%. So we'd be down 4 percentage points on fraction of inspired oxygen rather automatically.
Hyperbarics is a proven and accepted treatment for the central nervous system injury of deep-sea divers. Dr. Van Meter described an experimental Department of Defense study that is underway to use hyperbarics to treat brain injury received at ground level. Charles received this treatment, and his parents are certain that it helped him. Whether that is what turned the tide for him is a question we can't answer at this point. But it'll be interesting to see the results of the Defense Department study. Another mystery is this. In stroke and many head injuries, the rule of thumb is that the improvement you see after 1 year is about as much as you'll get. How did Charles make so much improvement in the 3rd and especially the 4th and 5th years post-injury? Was it related to his young age?
One of the analogies that I like to use about the importance of managing concussions in this younger population being what we have found to be more potentially vulnerable to the effects of a concussion, is that their brain is normally developing. Well, when they have a concussion and a brain injury, it's sort of like the pause button has been pressed on their brain's development in a way. And as a result, they may not move forward with brain development as quickly as they normally would because their brain is focusing upon healing. So our goal as the physicians taking care of those individuals is to get them symptom-free as quickly as possible so that that pause button could be put back on play.
Charles and his family are very relieved and happy that his pause button was released and his brain development was able to resume. They feel this happened when they finally got to head injury specialists. So when should a patient be referred to a head injury specialist?
Generally, what I'll recommend to other practicing physicians is doing so after that patient's symptoms have been lasting for more than a week or 2. Certainly, if you don't feel comfortable managing a concussion and feel that you can get that individual back to sport, back to work, back to school quickly, there's no shame in sending them to the concussion specialist in the acute phase in that first 1 to 2 weeks. In an individual whose symptoms are lasting beyond that period of time, I would recommend, though, sending them to a concussion specialist, as if you remember, 80 to 90% of individuals are going to have full resolution of their symptoms by 10 to 14 days if they're simply just rested.
Charles saw many specialists along the way. It seems that head injury is not a specialty of its own. It's seen by many specialties. How can one refer to a head injury specialist specifically?
The physician specialties that tend to take care of patients with concussions fall under a few categories. Physical medicine and rehabilitation and neurology both have extensive training in traumatic brain injury, including concussion. Both of those subspecialties also have potential involvement in additional fellowship training, such as a sports neurology fellowship or primary care sports medicine fellowship. In both cases, getting additional sports medicine training and specialized concussion training thereabouts. Both also have specialized traumatic brain injury certification within their subspecialties. Primary care sports medicine is another subspecialty in general, and I had alluded to that before. This involves primary care physicians, emergency room physicians, and also physical medicine and rehabilitation that do additional fellowship training in sports medicine that would include concussion management. Some orthopedic physicians that do a sports medicine fellowship may get training in concussion management, as can neurosurgeons.
Dr. Carlin says in addition to physicians, neuropsychologists are an important piece of a multidisciplinary approach to managing concussions, especially from the cognitive and emotional psychological aspects. Referral to a neuropsychologist can be extremely helpful, especially in an individual with post-concussion syndrome and persisting symptoms affecting schooling, emotionality, and such.
Another thing to keep in mind, though, is that one should not assume that just because the physician is a neurologist or a physiatrist or even a psychologist, psychiatrist, or neuropsychologist, that they have extensive training in concussions. That's something that is a niche within those subspecialties, and not all neurologists and PM&R doctors and sports medicine physicians are created equal when it comes to concussion management. So when sending a patient to someone for concussion management, you really want to do your due diligence to make sure that you're looking for someone with a concussion management specialty and experience.
Today, there are new developments on the horizon that will further advance the diagnosis and management of head injury.
There's potential thoughts of using functional MRI, PET scans, or even a blood test looking at a specific protein that's elevated in the brain after brain trauma as potential aids for diagnosis of concussion. Finally, in terms of treatment for concussion, we're looking at a number of new rehabilitative principles or protocols, looking at vestibular or balance rehab, neuroocular rehab. Sometimes we find that the neuroocular system is actually off in the individuals with concussions that cause persisting balance or persisting visual disturbance and headaches. We're also looking at other types of treatments for emotionality and the like. Unfortunately, the still basic paradigms of relative activity restrictions, emphasizing both physical and cognitive rest to a certain degree initially, and then initiating a graduated return to play schedule over time, is the treatment protocol.
With all the benefit of hindsight and what has been learned in the meantime, it now appears Charles suffered a total of 4 head injuries or insults to the brain. 3 of them went unrecognized. The first was in the soccer game and may have included a basal skull fracture. The second occurred when he returned to soccer practice before the first injury had healed, causing him to suffer a more serious and longer-lasting brain injury. 8 months later, just when he was finally getting better, the third injury or insult occurred. The cross-country air travel brought his symptoms and functioning back to his previous lowest point. The fourth was the subsequent flight that immediately precipitated new and worse symptoms than Charles had ever had. At no time during that first year had he ever healed. He never returned to that baseline that permits a graduated return to normal activities. His physicians were all aware of the initial concussion, but assumed he had recovered from it. Depression came to be accepted as the sole explanation for his symptoms of sleeping long hours, continued headaches, and isolating himself in his room for many months. Subsequent providers in every specialty appeared to accept and double down on depression as the sole explanation, even as they noted a history of head injury. No one advised against flying because hardly anyone then, and not many now, are aware that some head-injured individuals can be harmed by air travel. It appears in retrospect that Charles was one of those individuals. Charles's mother is an occupational therapist who sought out extra training in head injury. Despite having her concerns dismissed, she never stopped bringing up to the physicians that Charles's symptoms all began with a head injury. 2.5 years after the injury, Charles was still in bed in a darkened room. At that point, the whole family pulled up stakes and moved across the country by train to seek new care for him. Fortunately, over time, his pegs were gradually put back in the switchboard. His pause button was lifted, and his brain development resumed. It's a tribute to him and all his family members that he has finally made the long journey back to healing and recovery. We thank the physicians who offered their comments, and especially Charles and his family for their generosity in telling their story. We'd like to direct your attention to the bibliography that will provide clinical practice guidelines on head injury from different specialties, plus patient education resources. This concludes our presentation. We hope it's of use to you in your practice. Thank you. Thank you. Thank you. Thank you.